Welcome to this explainer. We're diving straight into the surgical management of myelomeningocele. This is a complete, step-by-step clinical pathway. We are going to cover everything you need to know without skipping any vital details, focusing intensely on preserving function and improving lifelong outcomes for these patients.
Here's our roadmap. We'll hit timing and pre-op decisions, core surgical principles, the closure technique, post-operative management, late problems and complications, and finally, long-term patient outcomes. Let's get right to it.
Section 1. Timing and pre-op decisions. The clock literally starts ticking the second the patient is born.
So the very first major decision? Timing. You really want to close that defect within 24 hours, whether the membrane is intact or not. Why the rush? Well, by about the 36-hour mark, the back lesion gets colonized by bacteria. That skyrockets the infection risk. Now, to be clear, closing early doesn't magically bring back lost neurologic function, but it is absolutely crucial to beat that 36-hour colonization window. You have to prevent those devastating infections.
What about a VP shunt? If there's no obvious hydrocephalus, most surgeons just hold off for about 3 days post-repair before shunting. But if the infant is born with clinically overt hydrocephalus, ventriculomegaly, enlarged head circumference, you actually want to do a simultaneous closure and shunting. It's a real game changer. It cuts down hospital time, doesn't actually up the infection risk, and it massively lowers the chances of the myelomeningocele repair breaking down while you're waiting.
All right, we're heading into surgery. Positioning here is incredibly specific. You place the patient prone, turning the head to the right to expose that right occiput for a potential shunt. Standard practice is to flex the right knee and thigh to expose the right flank. But here's a fantastic pro tip. Consider using the left flank instead. Why? Because it completely avoids any confusion with a future appendectomy scar down the road. Talk about surgical foresight, right?
Section 2. Core surgical principles. Let's establish the absolute non-negotiables for the operating room.
Before making a single cut, we've got to lock in our goals. Number 1, free the placode, that exposed neural tissue, from the dura. This is crucial to avoid future tethering of the cord. Number 2, achieve a strictly watertight dural closure to stop any spinal fluid leaks. And number 3, get a complete skin closure, which you can almost always pull off. And remember our mantra here. We are preserving what's left, not restoring what's lost.
You have to treat this neural tissue like the incredibly fragile structure it is. The OR environment has to be meticulous. Keep the tissue constantly moist so it doesn't dry out. The whole setup must be strictly latex-free since these kids are at a really high risk for developing allergies, sometimes even from maternal antibodies. Absolutely zero unipolar cautery. Passing that electrical current could fry the delicate spinal cord. And do not use any scrub solutions or chemical antimicrobials directly on that intact placode. Just don't do it.
Here is a crucial tip for the closure phase. Always start up at the normal dura and work your way down. You'll need to undermine the skin to get a nice, tension-free closure. But listen closely to this warning. You must strictly avoid trapping any skin during this process. If you accidentally roll skin under, you are basically handing that patient a congenital dermoid tumor later in life. Every single layer has to be perfectly separated.
Section 3. The closure technique. Time to break down the actual layer-by-layer mechanics.
Ideally, surgeons shoot for a 5-layer closure. Sometimes you can only manage 2 or so, but 5 is the goal. Now, this multi-layer approach doesn't necessarily improve function right now, nor does it guarantee the cord won't tether later. So why do it? Think of it as an anatomical insurance policy. If the cord does retether in the future, having those clean, distinct layers makes any subsequent untethering surgeries vastly safer and easier to navigate.
Let's zoom in on how this is actually built. First up, you painstakingly divide the abnormal epithelial covering from the normal skin. You separate the pia arachnoid from the neural tissue. Then, and this is amazing, you actually fold that extremely delicate placode into a neat little tube. Finally, you approximate the pia arachnoid right around it, securing the whole thing with a superfine 7-0 absorbable suture, something like PDS.
With the placode secure, you shift focus to the dura. You isolate it around the edges, following it deep into the spinal canal, and form it into a watertight tube. If it's just too tight to close, you might have to judiciously trim the placode a bit. Oh, and if you spot the filum terminale, that fibrous band at the base of the cord, you divide it right then and there. Finally, safely mobilize and close the skin over the top.
Before wrapping up in the OR, what if there's a skeletal issue? If the infant has a kyphotic deformity, you handle it right then, at the exact same sitting. No second surgeries for this. You just use a ronger to bite away that kyphotic bone to reduce the deformity, and then suture the adjacent bones together with 2-0 Vicryl. Whether you use a brace afterward, that totally depends on the individual surgeon's preference.
Section 4. Post-operative management. The surgery is done, but the critical care has just begun.
Post-op on the ward requires absolute vigilance. The physical rules are strict. Keep the patient entirely off their incisions. No pressure whatsoever. They'll need a rigid bladder catheterization schedule. You're doing daily head circumference measurements, or OFC, to hunt for hydrocephalus. And if they haven't been shunted yet, keep them completely flat to reduce CSF pressure on the fresh repair, and run head ultrasounds maybe once or twice a week.
Okay, pay close attention to this next point because it is literally a matter of life and death. You must absolutely avoid narcotics for post-op pain management. Why? Because these specific patients almost universally have an underlying midbrain malformation. That structural issue makes their brains uniquely and severely hypersensitive to respiratory depression from narcotics. Just don't risk it.
Section 5. Late problems and complications. Transitioning our focus to lifelong monitoring.
As the child grows, our radar has to shift to long-term risks. And here is the golden rule of myelomeningeal safe follow-up. If the patient deteriorates neurologically in any way, you immediately rule out a shunt malfunction, always. Shunt issues can mimic literally any other complication. But you're also watching for syringomyelia, those fluid-filled cysts in the spinal cord. You're looking out for dermoid tumors at the surgical site, which happen in about 16% of cases, plus symptomatic CARI2 malformations, and even short stature.
Then there is tethered cord syndrome. This one is fascinating. Up to 70% of these kids will actually show a tethered cord on an MRI scan, but, and it's a big but, only a small minority actually becomes symptomatic. When it does act up, it shows up as delayed neurological deterioration. Since there's no magic test that says, hey, it's retethering, you rely entirely on incredibly close clinical monitoring to catch that decline early. Section 6. Long-term patient outcomes. Let's see what all this intense work actually achieves for the patient.
The data here is just a massive testament to modern neurosurgery. Historically, without treatment, survival was dismal, maybe 14 to 30%, and that was mostly the mildest cases. Today, with the clinical pathway we just walked through, we've pushed that survival rate up to an incredible 85%. When we do unfortunately lose patients, early mortality is usually driven by Chiari-related respiratory arrest. Late mortality, on the other hand, is almost always tied back to shunt malfunctions.
But what about quality of life? It is heavily shaped by our early care. A stunning 80% of these kids will have a normal IQ, as long as we strictly prevent shunt infections, which are the main culprit behind cognitive drops. Around 40 to 85% will become ambulatory with bracing, though honestly, many opt for wheelchairs later on just for the ease and speed. And while true urinary incontinence is rare, only about 3 to 10%, most patients can successfully stay dry using intermittent catheterization.
So it all leaves us with a profound question to wrap up this explainer. Knowing the staggering difference early intervention makes, how do we best balance that adrenaline rush of neonatal surgery with the decades of multidisciplinary vigilance these patients need? Because that highly technical surgery we do in the first 24 hours, that's really just day one. Constantly monitoring shunts, watching for tethering, supporting development, it's a monumental challenge. But looking at those survival and IQ numbers, it is absolutely, without a doubt, worth every single ounce of effort.